Okay, so we have a tour group that's going by, and they keep looking in the window and freaking me out, but I'm going to try and continue on anyway with them staring at me. I'm going to stare back at them for a minute. We're going to talk about adjustment disorders. Adjustment disorders happen a lot with kids, and which is kind of nice because we're going to segue into childhood psych here. It is an assessment. It's done the same as depression. The interventions are done as the same as depression. And it's when there's been some sort of trauma that's occurred, and they just really, they lack the skills for adaptation that are necessary. My daughter, well, my niece, who I am raising for my sister now, is diagnosed with adjustment disorder. And so we do a lot of intervention, antidepressant interventions. We don't do meds. I don't want to do meds in somebody who's only 8 years old, or her brother who's 5, who sees a psychiatrist too, with adjustment disorder. I don't want to do that. But anyway, it takes some time. It does. Lots of positive reinforcement, a lot of reiterations at how they are positive people. The next slide is a diagnostic. It's development of emotional or behavioral symptoms in response to an identifier stressor occurring within 3 months or onset of the stressors. Well, both the children were present when my sister was killed, so obviously that was the stressor. Of course, Wyatt was only 1 and Tiffany was 5. So she is the one that's suffered the most, I think, with the, it's almost like a PTSD event, the adjustment disorder. They don't really outgrow it, but they learn to cope and adapt, which is challenging for adults, let alone children. So you can read the diagnostic criteria there if you want to. And then, finally, those people have gone by. The grief and loss slides are after this, but we've already discussed grief and loss, so I'm not going to talk about grief and loss. Again, it was on exam 1. I'm not going to revisit it. We're going to move right on into child psych. Okay. Child psych. I call it child psych. I've put it into this whole category. It's several chapters in your book that cover neurodevelopmental disorders, which is chapter 22. Not going to be here. Chapter 22. So we'll just start there. All right. So neurodevelopmental disorders, not diagnosed easily in adults. It's a lack of abstract cognitive abilities and verbal skills. It's constantly in change. Similar problems of adults, such as mood, anxiety, eating disorders, and usually diagnosed in childhood or adolescence. So we're talking about autism. You'll find out. Hang on. Below level intellectual functioning, and they usually have some problems with their IQ less than 70, accompanied by problems in communication, self-care, work and leisure, health and safety, social and interpersonal skills. So they have a difficulty coming from the inside out. Okay. Intellectual functioning is pretty low. So can be hereditary, it can be maternal alcohol use, prenatal problems, environmental influences, that can happen. Some people say autism is caused by immunizations. There is no literature to support that, none. So, autism spectrum disorders, this is what the DSM-5 has, and it is autism, Rett's disorder, childhood disintegrative disorder, and Asperger's fall underneath that spectrum. Again, it's the DSM-5, it's not the DSM-4. Another reason they switched to the 5 was to reclassify some of these into more billable conditions. Not that it's a billable book, it's not. It has nothing to do with that. It's all about how to classify according to signs and symptoms. It helps with your plan of care. But if it makes it easier in insurance companies, we're all for it. Psych's all for it. So autism spectrum is a severe impairment of reciprocal social interactions, communication, and usually they have some sort of stereotypical behavioral patterns. The flapping, you see that. The covering the ears, screaming, running in circles, because they are hypersensitive to sound. Those are kind of some of the classic behavioral ones. Let's see. Boys more than girls. Very little eye contact, few facial expressions, limited gestures, head banging, body twisting. Really can't pretend or make believe. Very realistic, concrete. With autism, they say it's genetic. There's the vaccine. Tendency to improve, but it's forever. It lasts into adulthood, and they have decreased behavioral symptoms as a goal, and special education is usually needed with language therapy. I have a very good friend, her son is autistic, and he is 22 now. He has to live at home. He could live in a group home, but he's so high functioning, and he does read, and he reads very well. Sensitive to touch. He still does a lot of the behaviors, but at the same time, he's not as limited as it's presented in the DSM. Let's see. Rett's disorder, multiple deficits, almost exclusively in girls, which is basically their development is just fine, and then all of a sudden their intellectual development stops. Everything just kind of stops for them. That's called Rett's. Childhood disintegrative disorder is regression in multiple areas of functioning after 2 years of normal growth and development. Has a lot of anxiety and agitation. I think I would be anxious and I would be agitated if I were moving right along like everybody else in my class, and then all of a sudden I didn't. So they call that childhood disintegrative disorder. Asperger's, very similar to autism, they're just more high functioning. Lots of clumsiness, more frequently in boys and girls. So we have a question. Which of the following would be considered autism spectrum disorder? And that obviously is C, isn't it? Rett's. Yep, because we just went over it. Okay. Expressive language disorder is communication disorder, and the learning disabilities and intellectual disabilities are a separate classification of disorders. My daughter is learning disabled, which is in the DSM-5 criteria. So it is not a borderline intellectual functioning, but it's a different intellectual functioning. Autism spectrum related disorders are tic disorders, learning disorders, motor skills, communication disorders, and elimination disorders. And those people are staring at me again. Hello. Anyway, tic disorders. Everybody knows what a tic is, so I'm not going to belabor this with what a tic is. Repetitive movement. Usually they have to give them some sort of atypical antipsychotic. Tourette's is a kind of tic disorder, but it involves vocalizations. Hi! Involves some vocalizations. Chronic motor or tic disorder, it can be either or. It's usually not both, but we're going to give them some sort of antipsychotic for that. Learning disorders, they may have achievements in reading, math, reading expression, but they're below expectations for the child's age. Or level of intelligence. My Gabby she is so smart. She is so smart. She is in the 8th grade and she reads at a 3rd grade level. That's okay, because there are so many things that she is talented at doing. Just reading is not one of them. Usually there's some sort of interference with academic achievement, life activities, development of self-esteem, social skills. Like I said, she's my dark horse. I've said that in class many times. She doesn't have a lot of friends, tends to keep to herself, and that's just classic for learning disabled, classic. So if we can get them into some sort of IEP, which is what a lot of the kids are using, we can increase their outcomes. And Gabby tells me she's going to be a nurse. So, and we do have accommodations here on campus for people who have IEPs, who want to go into the nursing program. And so it is a possibility that she could do that. Motor skill disorders, that's developmental coordination disorders. It's marked impairment of coordination, which pretty much you're going to fail gym. It's a bad disorder. Sometimes it comes with a communication disorder also. So we have to do a lot of sensory integration to foster normal growth and development. We want to get them back to where we need them to be as soon as possible. Communication disorders, this basically they aren't able to communicate very well with the outside world. It can cause some problems with socialization. It can cause some problems with growth and development. There's expressive language disorder, mixed receptive expressive, phonological disorder, stuttering disorder, and speech therapy is wonderful for all of them. So God bless speech therapists, I love them. Elimination disorders, in your paresis is defecating in or into inappropriate places with the kids at least 4, and it can be intentional, it can be involuntary. Every little kid is going to go to the bathroom outside. Okay, so don't freak out if your child is defecating on the lawn. They see dogs do it, cats do it, and they want to try it too. You just have to educate them that that's not correct. Now the problem lies when it interferes with, and it's an everyday thing, it interferes with normal functioning. They don't ever use the toilet. So I would not call it an elimination disorder unless it was pervasive. Enuresis is urination during the day or night, enclosed in bed after the age of 5. Most of the time it's involuntary, and I want to qualify this too because this happens more in boys than in girls, because boys tend to have a smaller bladder than girls do, and so they're more likely to wet the bed more often and into later years than girls do. So kind of keep that in mind, that enuresis is and nocturia is common, is more of a common occurrence in boys and girls after the age of 5. Work with them, let them grow, wait till their bladders are big enough. Don't let them have a lot of liquids before bed. And I wouldn't call it a disorder again until it's pervasive and they're 17 and they're still wetting the bed. Then I would probably have an issue that they have some sort of elimination disorder. Okay? ADHD. And I'm glad to say my son does not have ADHD. He's been diagnosed, well, my nephew/son, with anxiety disorder like his sister, and adjustment disorder. So we're going to be going back through and revisiting those therapies. But he doesn't have ADHD, which is overactivity, impulsiveness, inattention. Starts usually diagnosed when the kid starts school. And Wett's preschool teachers kind of picked up on his hyperactive nature and behavior, but really it wasn't hyperactivity, it's anxiety and anxiety relieving behaviors that he was exhibiting. So oftentimes they're ostracized, they're noisy, disruptive. If they have ADHD, they can't hold back, they don't remember their homework, they don't know why. They think it has something to do with information processing in the brain. Some people say it's environmental, cigarette smokers, prenatal influences, genetic links. It happens across the world, so it's not exclusively in the United States. No one treatment, but we need to reduce the hyperactivity and impulsivity. A lot of times with ADHD children, they're going to give them stimulants, Adderall, Ritalin, things like that, which interestingly in the ADHD child decrease that level of hyperactivity. Now in adults, when they take it, it's going to be a stimulant. So sometimes when I was working in private practice, I would see an ADHD child who's now 22 and still taking Ritalin. It doesn't work the same way when they're that old. So they've developed an addiction, and now you have another problem. So it requires a lot of attention, a lot of interaction between parents and their caregivers, and helping the child as they mature through changes in the brain function to a point where they don't need that stimulant anymore. So we want to work on behavioral strategies, environmental strategies, help with the parent. These children with ADHD are highly creative children, so get them into some sort of creative activity that helps them focus in addition to the meds, so they can practice that. Because by the time they get old enough, we're going to have to wean them off of those stimulant drugs. We talked about the stimulants. Antidepressants can be a second choice. And then we have non-stimulant medications, SNRIs, or the antihypertensives. And again, if you're talking about children, that's a little bit tricky because their body's just not quite set up the way it's supposed to until they're 16, 17 years old anyway. So actually titrating an antidepressant medication is going to be tricky at best. So we use atomexetine as a stimulant, and that's not a stimulant, it's an anti-stimulant, SNRI. So that's a false statement. So we want to do some sort of assessment for the ADHD. We want to look at their history. Were they fussy as a child, out of control? What do they look like? How can they sit? Can they carry on a conversation? How is their mood, frustration? How do they think? Because they're chaotic. It's just chaos when you're trying to talk to an ADHD child. When you're talking to a manic, and we'll talk about mania in just a bit, but when you're talking to a manic patient, it can be a struggle to stay with them because of flight of ideas. Flight of ideas is correct. Flight of ideas, they are way off on tangents. You can never bring them right back. ADHD children are the same. So we want to look at their intellectual processes. Like I said, they're very creative. We want to think about their insight. We want to think about their impulsivity, because a lot of times they're very impulsive. They'll just jump right in, not even worry about the consequences. If they have problems with other children, if they have problems as a result of their behaviors. We want to look at the risk for injuries, look at their role performances, and we want to keep them safe. That's ultimately the goal, is to keep them safe, keep them not interfering with other people, help them to complete as many tasks as they can possibly complete. And I think that is just about everything there. All right, so which of the following would the nurse most likely assess in a child with ADHD? I'm going to say C. Oh, impulsivity, of course. So they lack it. So children with lack of impulse control, probably ADHD. Now, we have to teach our parents, because frequently ADHD children are also abused children, because parents can only take so much behavior before they're going to react unless they're taught differently. So we do a lot of parent education, help the child with anxiety, help the child with coping, and there's our magic word again. And there's a whole scale. You're welcome to look at it, chapter 22, box 2, on how to measure all of those. So what are we going to do? We're going to help the children with autism spectrum disorders to reach their full potential as best we can. And we're part of a team, so we're there along with the teachers and the family and the speech therapists and pediatricians, all striving for the same goal. Just remember that we need to do what we can. Treatment option for ADHD includes educational interventions. Yes or no? That is true. We have a lot of education that has to be put forth to the parents, put forth to the children. So again, there's another tour. So It must be new student day or something today. Sorry. I'm very distracted when people are staring at me through a window. Anyway, self-awareness issues. Parents, they have to recognize their own system of beliefs, and how they are going to parent is going to be different than how somebody else is going to parent. Oftentimes I find myself jealous of people who have these wonderful kids that listen to everything they say. They do exactly what they're supposed to do. They do it when they need to do it. They listen. Instead, I have some children who have some mental issues because of things that happened to them early on. And they require me to be a little bit more creative in the parenting realm. I understand that, and I understand and accept the jealousy. So you need to understand that as a nurse, that not all parents have the education that I have as far as that goes, and that you might have to educate them and validate what they're feeling and move forward and assist them in realizing what their child's strengths are, what their strengths are as a parent, and how they can have a positive impact. What kind of support system do they have? It's very important to do that, because when you're taking care of someone with a mental disability, you're not just taking care of the patient, you're taking care of the whole family. And you guys should know that by now. I hope you do. Disruptive disorders, behavior disorders, this is a little more challenging. These behaviors are characterized usually by anger and hostility, aggression towards people or property, and this is diagnostic. ODD is the first one that comes to mind, is a precursor for antisocial personality disorder. It's just called ODD when they're children. ODD, oppositional defiant disorder, intermittent explosive disorder, and conduct disorder. Oppositional defiant disorder is the one that you see where they lack remorse as children. They'll kill animals and they really don't care, that kind of thing. Intermittent explosive disorder is where they take it in, they take in stress, and then they just blow up. You'll see this sometimes still diagnosed in adulthood. It is a childhood diagnosis, but it can still be diagnosed in adulthood or carried with them to adulthood. So don't be surprised. Don't be surprised if you see it on somebody's chart up on 4E, because it's usually just carried over. Disruptive disorders, I already said that. Oppositional defiant is a mild form of conduct disorder. I don't know if I believe that, but some people say it. Intermittent explosive as an impulse control disorder. I can see that. They can't control their impulse to hit somebody. Okay, that's just some theories. Let's see. So I guess we're going to talk about intermittent explosive disorder first. It involves aggression towards people or property, so they can't stop themselves. Adolescence, young adulthood. It's a childhood disorder. It is a childhood disorder that carries on into adulthood. The official diagnosis happens in childhood, not after the 18, it should say before the age of 18 years, but it continues on after the age of 18 years. So I guess I missed a few types in there. Characteristics, episodes of impulsive, aggressive, violent behavior. Episodes are less than 30 minutes. They have physical injury, destruction of property, or injury to the self. May feel guilty or remorseful, but not able to refrain from doing it again. So maybe they bang their head against the wall, cause a concussion. It doesn't last long. They stop, and then they can't help but do it again later on down the road. They just do it. It's an impulse, which is why some people say it's an impulse control disorder. Occurs mostly in men, children, boys. 80% usually have some sort of substance abuse disorder, ADHD, ODD, depression, conduct disorder, and it's related to childhood trauma. Neurotransmitter imbalance, they think, is responsible. Tryptophan depletion, frontal lobe dysfunction. They don't know what causes it. They really don't know what causes it. So that's what they think causes it. So obviously, if it's serotonin, we're going to give them antidepressants, possibly. Mood stabilizers. Cognitive behavioral therapy, go back. Anger management, relaxation techniques. And they really can't get addicted to substance use because they will abuse. They can't stop abusing. So which of the following consider a characteristic of IED? C. I'd say C. Yay, and I'm right. They hurt themselves or they hurt others. Nothing we can do about it. ODD, we've talked about it. They're very hostile, very disobedient. Usually they don't have any antisocial features in the beginning, but they develop them. Begins in childhood, goes into adolescence, and 25% get contact disorder. 10 go on to become 10% antisocial. I don't know if those are correct. That's what's in your book. I think the statistics are much higher for the antisocial disorder, but in ODD, they have dysfunction socially, academically, work. They really can't solve problems very well with low attention, low flexibility, and decision making. More in men than in women. Children have lower self-concept. They lack confidence, lack insight. Basically everything I've just said. ODD is pretty scary. It's believed to be genetics, temperament, and adverse social conditions. Now, that being said, because antisocial personality disorder is a lack of developmental crisis of trust versus mistrust, I can easily see this being on a continuum with that and being, again, an Erickson problem or a personality disorder. Genetics do play a part in some control of impulse, but not necessarily with a child who's always going to tell you no. Likewise, the child who looks at you and argues with you just for the sake of being arguing is 4 or 5. They're not ODD, okay? Not necessarily ODD. So don't take it to the extreme and say, oh my God, my kid has ODD because he argues with me every time. No, not necessarily, okay? Maybe it's an adaptation because of poor social occurrences. So we have to teach the parents how to ignore the behaviors. Easier said than done. You're out at the Waffle House and the kid is screaming and telling you no, 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 and hitting you. You won't go out and you won't beat his butt. Set him in the car for a while. We have to teach them to ignore those behaviors. We have to teach them to reward, like Skinner. If they're good, they get a reward. If they're not good, they don't get a reward. They get ignored. But individual therapy is usually best. All right, another question. Anticonvulsants, mood stabilizing medications are frequently used to treat ODD. False. We're not treating ODD with those. We are looking at behavior. And we can reward that or we can not reward that. Conduct disorder. Persistent antisocial behavior, and it depends on if it's childhood, adolescence. So onset before age 10 or onset after the age of 10. It's mild, moderate, severe. They think it has to do with genetic vulnerability, environmental adversity, and poor coping. Again, trust versus mistrust. Personality disorder is antisocial personality disorder. Is that where it comes from? That's what they say. Conduct disorders on the spectrum with antisocial personality disorder, they're saying genetics for that. Who knows? They don't really know. That's what they suppose. We need to know what they look like. There are some risk factors. Trauma is definitely a risk factor early on, so we want to get in there early with them for parenting education, social training, family therapy, and then sometimes they need meds. Sometimes they need some meds to help with not behaviors, but with thought processes. We're going to do a history. We're going to look at their relationships. We're going to look at what they look like. We're going to look at their mood. Do they talk to you? Are they disrespectful? Are they quiet? Are they reserved? Do they kill animals? Do they steal things? My cousin is a therapist for some children, high risk children. And he has some that are conduct disorder, and one of them actually, he works for the school. The school, he got out from school, went to the store across the street, took a basketball, I think. He ran out the door, told him he'd come pay for it later. The police chased him down and handcuffed him. He's 9. Police chased him down and handcuffed him. And when my cousin came to find him, or come to talk to him, he asked him what made him do that, and he said, because I wanted to. And that is obviously a conduct disorder. It's very difficult to treat that. We're going to assess thought processes, content of thought, intellectual processes, judgment, self-concept, rules and relationships, and self-care. They're going to be very intolerant people, possibly violent, have very low self-esteem, like to break the rules. Which of the following would the nurse most likely assess in a child with conduct disorder? B, aggression towards animals. They're the ones who hurt animals. Okay? Or people. They're very oriented and capable of logical, rational thinking, but they have such low self-esteem they take it out on other people. So, risk for others, self-directed violence, and we want to keep them age appropriate, and we don't want them hurting themselves or anybody else. Okay. I think that's about it for that. Yeah. Again, revisit. It's not the parent's fault. It's not your fault. You have to realize how you think. You might say, gosh, I'm a failure. The parents might say, gosh, I'm a failure. That's not necessarily true. It is what it is. So you just got to realize and help them realize that they're going to have to parent differently than other people. How they can be positively impacting their children. They have to accept themselves. They have to accept their child. It's a very difficult time for everybody. A lot of family therapy is highly recommended. And that's it for child psych. I'm not really good at child psych. I really don't like child psych. I'm more of an adult person. But I understand it. So hopefully you understand it a little bit. It's a little more difficult to live it, I think, than just talk about it. So do your best. Like I said on the study guide for exam 2, I will have exactly what's going to be on there with the page numbers for 70% of the exam. There are some issues with child psych that I will have on there, and I'll tell you where to look. Okay? So let's talk about suicide. It's weird that I'm more comfortable talking about suicide than I am child psych, but I am. Again, I want to reiterate, separate suicide from depression. That's why I threw child psych in there for you to make that break. It's definitely a permanent solution to a temporary problem. The problem being that the people who are considering suicide or have suicidal ideation don't see it as a temporary problem. They see it as a way out, as an option. Suicide is an option. There is a difference. There are gestures, threats, and then the attempt. Gestures are non-lethal. Okay, they're a cry for help, so to speak. Borderline personality disorder frequently will gesture at suicide. They will cut, and that's very common for borderlines, and they'll cut this way. And it's mainly as a stress reliever that they cut this way. Now, if they were really trying to kill themselves, they would cut this way. Okay, and they know that. Most people who want to do suicide research it, and they know what they're going to do. But when you're cutting this way, or you're cutting on this side, you're cutting your hands possibly, cutting your chest, wherever you cut, it is a gesture. I actually had a student who had several marks on his arm, and I said, "Are you a cutter?" And he said, "Yes, I am." or I guess I was as a child, much younger. They were all scarred over and everything. So he obviously got it together. He's a very successful nurse in North Carolina right now. We're friends on Facebook. Good guy. But at the same time, it's a stress reliever for people. It's not lethal. Threats, that's like a verbal attempt or a verbal statement to get help, attempt to get help. And then the attempt is the actual going ahead, going forth with it. Copycat suicide. We had some of this a couple years ago out in Shawnee. I think one person killed themselves, and then other people were on board with that. And the reason they're on board with that is because they were almost given permission that it was okay to do it. And when they've been given permission to do it, then they're more likely to copycat the behavior. Families, that's another way of looking at it. If they copycat, it is they've been given permission, possibly by an elder, that it's okay, that this is an option, this is the way out. And that's a reason they're so common, especially among friends in high school, suicide pacts and things, or in families. You see more accepted behavior with that. Suicide statistics, I'm not going to give you a whole lot of statistics on this. Just know it's the very young or the very old. People between 30 and 60 are less likely to commit suicide. Okay, less likely. 14 to 25, 65 and plus, more likely. They've been increasing. 25 attempts for every one completion. 11th cause of death in the United States. Like I said, I'm not going to go into a whole lot of statistics. If you're interested, I have a whole laundry list of statistics on this. Psychiatric disorder, I'm not saying depression, psychiatric disorder in general is a risk factor. Alcohol, being a man, increasing age or very young age, so the very young and the very old. Caucasians. I think the reason that is because as a class of people, Caucasian individuals have less of a social support system than other classifications or ethnic groups or races, if you will. They're more broadly defined. They don't have little sects. Yes, I'm Caucasian, but at the same time, I take great pride in being a part of the Melungeon group, which I've told you about before, that offers a sense of belonging, love and belonging, which is a higher need that everybody needs. In general, if you're looking African American, if you're looking Native American, if you're looking Italian American, you're looking at different subcultures within the sect, Hispanic American, they all have a greater bonding experience than Caucasians in general. So you may say to yourself, well, some of those are, those are Caucasian classifications. Yeah, but it's what they belong to, I guess, what their subset, what they identify with, that sense of love and belonging. Whereas in general, Caucasian people don't necessarily have that bonding experience. They don't have a church they belong to. They don't have a subset they belong to. But anyway, they're more at risk for suicide than other races or cultures. Lack of religion, there's a lack of belonging. Marital status, divorced, lack of belonging, lack of love and belonging. Professions and physical health, higher stress professions, nurses, pretty high risk for suicide. Doctors, pretty high risk for suicide. Lawyers, yes, okay. And in poor health. Biological theories, I think it has to do with serotonin. So I think that's where a lot of people link it with depression, because of the serotonin thing. But low levels are not necessarily a cause for suicide. And again, that copycat suicide, that sense of permission, is why it tends to run in families, I think. Other disorders that have it cancer, cardiovascular, cerebrovascular, chronic renal failure, Cushing's, Huntington's, peptic ulcer disease. All those have a tendency to suicide. Freud, anger, aggression turned inward was depression. Suicide is acting on the anger turned inward. Menninger says that we want to kill people. We want people to kill us, so we act like we want to kill people, and we have a wish to die. Beck, he says it's hopelessness, hopeless, helpless. We just have to change our thinking, and we won't necessarily suicide. Let's see, societal factors with suicide. I love talking about this in class, so it's going to be kind of boring for me here, but I think of the Terry Schiavo case. I think of Oregon's Death with Dignity Act in '94. This came out right in the middle of my oncology experience. In Belgium, Switzerland, Netherlands, suicide is accepted. It's fine. The United States has an issue with it. I believe that if you believe, it goes back to the whole pro-life, pro-death, or pro-life, pro-choice. Okay, they're not really opposites. Pro-life means that you value life in any way, shape, or form, and that's going to be somebody with end-stage COPD who's screaming in pain. Then you have to support that they have the right to live, and that nobody's going to kill them until a natural death occurs. That's right to life. Okay. Death with dignity is the right to death. Okay. Pro-choice is not the right to life or the right to death. I want you to think about that. Pro-choice is just allowing someone to make a decision. That's all it is. So when you're talking abortion issues, pro-choice is you saying, you know what, it's not my place to tell you what to do. Whereas pro-life is, I'm telling you can't kill the baby. Okay, think about those things. If I had someone in oncology, and I've had several people in oncology, who asked me to help them commit suicide, I would have to think long and hard about that. That's not my choice. My choice is a natural death for whoever is it happening to. I wouldn't want to increase that. If they choose to do that, should they be able to do it on their own? Should it be legal? Who knows? Oregon says yes. Netherlands, Switzerland, Belgium, they all say yes. But you can't be pro-life and believe in euthanasia. Not if you are a strict believer in the ethics of it. So, something for you to think about. Assessment and suicide. They're going to give you verbal clues that they're thinking about it. Non-verbal clues. They're going to tell you their plan, high risk factors, and there's stages of suicide. Stage 1, 2, and 3. Are they going to do it? First thing you need to do, and wrap your mouth around it, are you going to commit suicide? If they don't understand what that word means, or you don't think they understand it, are you thinking of killing yourself or somebody else? Wait for a response. Do you have a plan? Wait for a response. And then you got to figure out how to ask them how they have access for the plan. In other words, we had a patient, one of the students I was just with these 5 weeks, the first 5 weeks, the patient said he was going to walk into the woods and hang himself. My next question would be, do you have a rope? In other words, do you have access to the plan? That's what you have to figure out how to ask them. And if he says, yes, I have a rope, then you're going to go into and you're going to say, they have access to the plan. Then you have to take some action. You have to prevent jumping off the next bridge I see. Well, the next bridge may not be for 15 miles, so that's not really a plan. If he says, yes, I have a gun, that's a plan. Okay. How lethal is the plan? You have to consider that. If the person says, I'm going to take a whole bottle of pills, well, guess what? Pills don't kill people on general. Usually they don't. Very determined. Car accidents will kill people. Someone takes out their seatbelt and runs into a tree. That's going to kill them because the tree is rooted into the ground. They take off their seatbelt, they run into a telephone pole, there's a chance they're going to survive. So you have to judge the lethality of the plan too. Let's move on. Covert statements and overt statements. Oh, everything's going to be okay soon. That's a hidden statement. That's covert. It's under the covers. So they're going to give you all sorts of things to question. And the tendency, I think, for most beginning nurses is to ignore covert statements out of fear that you're going to have to ask the question. Don't be afraid to ask the question. If someone says to you, it won't be long now and everything is going to be just fine, and they're accompanying that by giving away their personal items that mean things to them, and isolating, and all of a sudden seem very happy, that's because they've made a decision to kill themselves. And you need to ask them, you need to ask the question, you need to put it out there. Are you going to hurt yourself or somebody else? Okay, so they're reaching out for help when they do those things. And if you can see them and you can pick them up, reach back for their hand. That's all I'm asking. Overt statements, those are just overt, open. I'm going to kill myself. I can't live anymore. I wish I were dead. Overt statements. So you can pick up that and we'll go over the conversation. I gave you a laundry list of what's considered lethal and what's considered less lethal. Cutting is not so lethal. Putting your head in the oven. We don't have gas ovens anymore, but gassing themselves, trying to gas themselves. Aspirin, Tylenol, tranquilizers, although they can do some damage. No, don't get me wrong. Tylenol can put you into liver failure and that can kill you, but you also can be dialyzed out. So it's not necessarily a highly lethal means. Whereas jumping off something, hanging themselves, drowning, as long as there's a plan and they have access to the plan, that's a problem. Like if I told you I was going to go out into the woods behind campus and I was going to hang myself on the 15th tree down, you better be asking me, do I have a rope? Okay. If I say I'm going to go over and I'm going to stand in the middle of traffic over on Moomaw Road, that's not necessarily, a very lethal plan because people can stop their cars. Hopefully people will stop their cars and not say, hey, there's a psych teacher, I'm going to kill her. No, hopefully you'll do that. But anyway, well, you will stop your car. Okay. Anyway, you have to look at it. You have to say, okay, sleeping pills, yeah, that's going to cause some trouble. Extreme exposure to cold, antidepressants, carbon monoxide, drowning. How does somebody drown themselves? They put rocks in their pockets. Okay, they walk into the lake, Indian Lake, with their pockets full of rocks and they can't get up and out. Okay, taking a bunch of sleeping pills and getting in the bathtub. That's how people can drown themselves. Okay, and they do that. And they'll tell you very specifically what they intend to do. So you have to see someone who's at highest risk for suicide is going to be very young, very old, and usually have a gun or a gun collection. So think about that. Someone who's likely to do it over the age of 71 or 65, very independent, just can't, his body can't do what his mind thinks he can anymore, and he owns a gun. Okay, that's probably the most lethal plan, is if they have a gun and they're in those age brackets. So, let's see. Ideation is stage 1, stage 2 is just the threatening, and then stage 3 is the attempt. And we've already talked about this kind of where they think about it, they really don't care if they live or die, then they isolate and start giving things away because suicide's okay, and then they have accepted it and they're ready to do it, and then they attempt. There's a case study. I'm not going to go into this case study with you. You're welcome to read it. But you can see all the stressors that were happening to Tom here. and why he wanted to potentially end his life. Nursing diagnoses for suicide, potential for suicide. Ineffective coping, that's a big one. Remember, people don't cope, that's why they're ill, or they don't know how to cope. Hopeless, powerless, helpless. Spiritual distress, self-esteem disturbances. You just have to quantify it. You have to determine what's the most serious and how you intervene. Potential is less serious than a direct risk. And then you have to think about yourself. You have to take self-stock in how you feel about suicide or somebody who commits suicide. My children are devout Catholics, and they believe it is wrong, and they're going to go to hell, and that is just terrible, and blah, blah, blah. They just haven't seen a whole lot in the world yet. People who have been around in the world who have very little support systems. Some of my patients, for example, they would rather be dead than sleep under the bridge and get raped every other day. How do you deal with that? How do you deal with the junk it brings to you? How can you say, you just want to say, I'm going to take care of you, you can live here forever, and nobody's ever going to hurt you again, and you can't do it. That's not your place in the world as a nurse. How do you cope with wanting to do that but knowing you can't do that for the entire world? It's hard. You got to figure out, you have to do a lot of debriefing, venting. You guys use that term, venting to other people. You might be in denial about it. You might be anxious. You might get mad. Exercise. Use your positive coping strategies to get done what you need to get done and to de-stress yourself and realize you cannot take on the world. You cannot take care of everybody. And that's okay, because remember, nurses are high risk for suicide too. Okay, so take care of you. Crisis is temporary. You can survive pain. You are not alone. There is the Hope Line. Like I said, Coleman, interestingly, has a text line that you can text if you're thinking of committing suicide, or somebody's thinking of committing suicide, because the younger people, 14 to 25, usually are the ones that are doing all the texting. It's imperative that we stop this. In 2020, one of the goals is decrease the number of people who are committing suicide, and you guys are on the front lines. By asking the appropriate questions, you can make a difference. Okay. On 4E, they have something, it's a behavioral contract. They ask the suicidal client to sign stating that while they're there, they will not self-harm. Something about signing a contract tends to make people feel important, and when they feel important, they often will abide by the contract. That's the whole basis of the no harm contract that they put out there. It increases self-esteem to the point where the person is like, okay, I am not going to hurt myself because somebody thought enough of me to create this paperwork. So I hope that makes sense to you, but that's why they use it. Suicide precautions. This actually should be anywhere that there are people in crisis. You take their shoestrings, you take their belts, you take anything that they can hang themselves with, you take anything they can cut themselves with, you take anything that they can hit themselves with. If you're at St. Rita's, you'll notice that there's no trash cans in the room, and that's because we had a patient actually kick his trash can enough to make a shiv and then start cutting. We don't have a lot of things in the rooms that they can manipulate at the hospital level into devices to injure themselves with. At Coleman, they have blinds that have strings on them, which I don't like because we've had an active suicide there. I don't think it was related to that, but they did hang themselves within that 15 minutes that it took for them to make rounds on everybody and come back. The person committed suicide. It's been a couple years ago, but it happened. No razors, no matches. again, they're going to make 15-minute checks on everybody, regardless, because the psychopathy alone puts them at risk for suicide, not just depression, entire psychopathies. Unbreakable windows, the same, you're just going to see the mesh, the metal netting almost that blocks the windows from being broken to stop our jumpers. We have had jumpers in the long ago past from there. That's the reason we have the blocks on the windows now. And we're talking, 20, 30 years ago this happened. Yeah. And I don't think there's anything. They take perfume, any kind of glass containers, anything they can poison themselves with. That's another thing. You just have to be very careful, because when they want to hurt themselves, they will. There's a concept map if you're interested in it. I just kind of provided that with you so you could take a look at it. Some people's brains work like this, mine does not, but I've created this for you so you could look at it. Survivors of suicides, they need support. Like I said, copycat suicides run in families because it's the okay to do it, but some people don't want to do it. They just have to live with it, and we need to have support systems for them. A lot of times, talking about suicide is just, it's like when people talk about cancer, they tend to whisper. That's silly. But when they talk about somebody who's committed suicide, she killed herself, they tend to whisper. The little old people do. It needs to quit being a whisper. We need to talk about it. There's lots of shame, there's lots of guilt, but at the same time, if we assist our patients with their coping and help them realize it's not their fault that this family member did this, they can move past it. So we have a patient hospitalized with major depression and suicidal ideation. He has a history of several suicide attempts. He eats 20% of his meals for the first 2 days and stays in his room between groups. By the 4th day, the nurse sees him. He's more sociable. He's eating meals, has a bright affect. What should you think about? That he's ready to kill himself. He's happy now because he's made the decision. And is it showing improvement? May have decided to commit suicide. He's feeling rested. Is benefiting from the antidepressants he began taking 4 days ago. No, it is B. Okay. I gave you a website there, the GRASP website, and you're welcome to go look at that. It's for survivors of suicide, family members and survivors of suicide. Take a look, see if it's something you think you can use for your patients. You're welcome to use it as a recommendation. But like I said, don't be afraid to ask the questions that need to be asked when you are addressing someone with suicide, okay? And I think that's about all I'm going to do for today. I'm not going to talk about bipolar. Maybe next Tuesday I'll talk about bipolar and get it uploaded for you. And remember, all this stuff is for exam 2. Talk to you later.